Welcome to Roadmap to Residency Evidence-Based Applications. Hello everyone, I am Abhiraz, and in this video we will be discussing a brief concepts about pulmonary function test. So what is pulmonary dyspnea? So it can be due to obstruction or restriction. So obstruction is when the air can't get out of the lungs, air is trapped and there is poor oxygenation. And restriction is when the air can't get into the lungs and also there is poor oxygenation. So pulmonary function testing determines the flows and volumes in the lung. It helps to determine the cause of dyspnea, which is sometimes unclear from the history, examination, X-ray, and other tests. It helps to determine the disease severity and progression, and many diseases are monitored by PFTs about their progression and severity and their improvement. For example, in case of COPD and pulmonary fibrosis. So COPD, case of obstructive cause, pulmonary fibrosis is a case of restrictive cause. So spirometry is a method for assessing the pulmonary function. Pulmonary function test is through spirometry. The patient blows into the machine and volume of air is measured over time. So spirometry must meet criteria for adequate test. There is sharp peak in the flow curve and the expiratory duration should be more than 6 seconds. So whenever the patient blows into the machine, the patient should blow for at least 6 seconds. So here, this is the normal spirometry curve, okay? And here you can see this is the restrictive pattern of spirometry curve, where you can see the FEV1 is decreased, and also here you can see the obstructive pattern of spirometry curve. So FEV1 and FBC fall in both obstructive and restrictive diseases, but FEV1 falls more than FBC in case of obstructive diseases. So FEV1 means forced expiratory volume at 1 second. So here you can see this is at 1 second, and FBC means forced vital capacity. Okay. Now, in case of obstructive, the FEV1 is decreased more than FBC. So FEV1 by FBC is decreased. But in case of restrictive lung diseases, FEV1 is less decreased rather than compared to obstructive. So FEV1 by FBC becomes more than 80%. So talking about the flow volume loop. So now this is the peak expiratory flow rate, and this is a normal curve whenever the patient is exhaling. Okay. Now in case of obstructive lung diseases, you can see that the patient cannot get air out of the lung. Okay. So initially the patient is able to inspire, but later the patient is not able to exhale. That is, air is trapped. Okay. So the short form, the somewhat identical short graph of normal is the obstructive graph. Okay. And if there is formation of a U-shaped graph, okay, somewhat curve or U-shaped graph, which means that in restrictive, the patient is not able to inhale appropriately in the initial phase only. And if the patient is not able to inhale appropriately, then ultimately the exhalation will also decrease. So if there is this curving or a U-shape occurring into the graph, then that is called as the restrictive pattern. So this is the easiest way to determine the obstructive and restrictive spirometry curve, and it will help you a lot in the examination. So work of breathing. So whenever we talk about work of breathing, the first concept that we need to know is the airflow resistance. So if you breathe slowly, okay, then there will be less resistance. But if you breathe faster, then there will be less resistance. So airflow resistance means that whenever you breathe slower, there's less resistance. And if there is elastic resistance that is occurring, it means if you breathe faster, then there is less resistance occurring, which means that if there is collapse of the bronchioles and all, okay, and if you breathe fast, okay, if you breathe fast, you do not let the time to the bronchioles to collapse completely, and then you will provide less resistance. So the slower you breathe, less airflow resistance, faster you breathe, less elastic resistance. Thank you for watching. Keep studying hard.